My name is DJ Wilson. I'm one of the folks that helps put on State of Reform, and I literally am just arriving. I'm sorry I've missed you for the rest of the day, but it's been, I don't know if they explained this earlier. I'll get you here, my microphone, Erica. We are doing 2 events today. And so it's been a little busy. We have our Portland event because the legislature in Oregon scheduled committee days without asking us about when their event should be. And so we thought, well, it's not great to have a policy conference if you don't have any legislators show up. And so we had to schedule it. And the only time we could make that event was on the same day that we were hosting this one. So, but it was important for me and important for our team at State of Reform that I be here personally just to be able to say thank you for the support that you all and our sponsors give to State of Reform generally, but specifically here in Spokane. Being able to host this conference in this community is only able when you have stakeholders that are deeply engaged, and we have that in the way of sponsorships. We have that in the way of speakers, your attendance. I still have emails from some of you who gave me names of people to contact to begin our California expansion. Some people that I still have not followed up with. So thank you all for being here and for participating. The end of the day is usually a period of time where we're all a little bit tired. The sugar rush, has crashed, and the carbs have sort of let us down, and the dinner and glass of wine are still an hour or a couple hours away. But this is one of the most, I think, interesting panels of our agenda, because this is a set of speakers who are kind of living and fighting and dying in the hallways of Olympia, both in the legislative building and in the hallways of the agencies where, candidly, much of the policy is being created today. For some of our legislative friends may not share that opinion, but I think the lunchtime panel was indicative of all of the different things happening. So I will turn it over to Erica for introductions and let you take it from here. I just will also note that we have jerked Erica around probably as much as we have jerked anybody around when it comes to speaking. And Jeff, I think we got you lined up a week or so ago, and then we still didn't communicate as effectively to this whole panel as we should have in this run-up. So these guys are really great, and gal are really great, because we've not done a great job preparing you. So thank you for contributing in the way that you do and for participating. So with that, take her away, Erica.
Thanks, DJ, and thanks for setting a low bar. So there we are. It really is a pleasure to be here this afternoon and be with these fine gentlemen. I did note that I'm actually friends with 2 of these 3 gentlemen's wives who are also lobbyists, and they could have been up here just as easily as them. And I don't know Dr. Crittenden's wife, but I'm sure she's delightful as well. And I will tell you, your wives have given me some questions for you related to their anniversary presents. So before we jump into the first question, I'd like to introduce our distinguished panel. And I've asked them to say provocative things so that all those folks who left early can say, wow, you missed it. Dr. Crittenden's actually taking on Governor Inslee next year in the election, right? So with us today, to my left, immediate left, is Dr. Bob Crittenden. He has a slightly new role here. Maybe we can ask him to speak about it. He is the Special Assistant for Healthcare Reform for Governor Jay Inslee, a position. He has done incredible work, and I have to say personally, he's extremely accessible, and we really enjoy working with him at Empire Health Foundation. To his left is Jonathan Seib, who has also held many hats. If you were here this morning, you heard Lisa Brown say he was her best staffer, I think she said earlier in the day. He and his amazing wife Patty run Seib Consulting, and they have done a lot of work. I think probably Jonathan, these 2 gentlemen here are 2 of the deepest healthcare policy people in our state. We're fortunate to have them with us. And then finally, Jeff Gombosky, who is currently a contract lobbyist, and he holds a number of healthcare related clients. For those of us here in Spokane, we know that he represented the 3rd District, I believe from 1996 to 2003. I just found out he is also a Meade Panther, where my kids go to school, so go Panthers. So we're going to jump in, and I've got a number of questions. My little list has been expanded throughout the day from the discussion. And if we have time, we'll turn it open to the group. But I'm going to start off. My first question relates to predictions. So we saw in many of us read our friends at State of Reform's 5 Things We're Watching, and last week's noted that 2014, that legislative session was quite active when it comes to healthcare-related items. Of course, we had House Bill 2572, all-payer claims database. It was a lot of activity. 2015, in contrast, with regard to healthcare, was a little quieter. Health benefit exchange, that really dominated this year. So my first question to you all is, what can we expect for healthcare in the short session that's coming up on us soon? I'll start with Dr. Crittenden.
Well, I think the governor's office has been very trying to downplay a lot of things, basically because of the education issues in McCleary. We do have some important things, though, and one of them is that you've heard the 1115 waiver issue, and part of that is going to be, it has to be, if we do get the money, it has to be appropriated, even though it's not our state money, it's federal, we still have to have an appropriation. So the legislature will want to review and consider it and make sure it's the right thing to do. So there'll be a lot of work around that. And I think around the exchange, there was, I would say they weren't perfect last year on their fiscal matters, communicating that. And so there'll be I think there'll be some discussion and maybe some cleanup sort of bills where we can get a little more, I'll say, better information to the legislature so we can take care of that. As far as a lot of things, though, because of the 6312, 2572, the APCD, we have a lot of stuff going on. It's just not going to be as legislative. One thing that we, on the public health side, that it's really important is we have this healthiest next generation. I think it's been mentioned in the past. We had a long list of issues that were part of that. Interestingly, almost everyone was funded last year in all 3 budgets, in the sense of the transportation, the capital, and the operating budget. I think breakfast after the bell wasn't, but we didn't fund the actual operations of kind of the organizational staff to do that. So that's a hole that we may end up approaching this year as well. And the last thing is the vaping issue, which is developing into quite both a public health issue for young people as well as a fairly hard fight. And so the issue, there are 2 parts to it. One's the tax and one's the regulatory piece. And so we'll be looking at both of those.
So I think I would start by pushing a little bit on the notion of the 2015 session. And maybe it's my years on the staff side, where all I knew is I had worked my tail off and somebody dared say that not much got done. I don't want it to be diminished. And you heard mention all day today of things that were accomplished in the 2015 session of significance. Lisa Brown started this morning and mentioned the pharmacist bill. I don't know that the significance of that is as understood as probably it should be. That probably was a decade-long effort. To put pharmacists in this state in a position to be a very meaningful part of a healthcare team, and really put this state in the lead in terms of trying to figure out how to make that work. The telemedicine legislation that passed has been mentioned a number of times. It's something that the state will build on in terms of the opportunities that it will provide for better care, particularly in rural areas. I don't want to diminish the work that Bob did this past session on the all-payer claims database. All by way of saying, don't be cautious in assuming because it didn't necessarily make the headlines as contentious that there was not a lot done. One Jeff may talk about is the work on biologics, very tough issue that was finally some progress was made this last session. That being said, I would agree that the next session, or maybe I will say this because it may not be the next session, the next regular session in 2016 will probably largely be defined by the efforts of the legislature to address education funding, helped or hindered by what may be a fourth special session this year, depending on how the conversations go with regard to responding to the Supreme Court. It will be defined by the fact that it's an election year and a very significant election year, and that will color what can and what does get done. And probably third, one of the things that my years there taught me, it's a very, very human institution. And the fact that you had these folks there for 176 days, maybe more this year, and that many of them will be going fairly quickly post-session into a re-election mode that will again take them away from families. I think that the appetite given these things for headline-grabbing things in healthcare may be small, but I consider it will be what I think clean up, follow up, and set up, which is cleaning up and following up from the stages that were set in the past session. Things like the vaccine exemption, some of the things Bob talked about in terms of public health, legislation that was introduced and discussed for which there may be a path to the finish line next session, and then setting up in terms of trying to lay the groundwork for what might be considered in the next biennial budget session of 2017. When it's not just, if you will, just a supplemental budget year, things like appropriate Medicaid payment that will require a significant budget discussion. The operation of the waiver, the operation of the exchange. So, like I say, I am not wanting to diminish those non-headline grabbing things that occur during a legislative session, but would tend to agree that there's a variety of external factors that suggest that there will not be a lot of headline grabbing activity in the healthcare arena, at least in the upcoming session.
I predict that both Dr. Crittenden and Jonathan are correct in everything that they said. I think that we've seen, obviously, in the last 5 years since the adoption of the Affordable Care Act, this state deal with lots as it relates to policy. And I think, to Dr. Crittenden's point, that we've got the agencies and so many others looking at the implementation of reform. So I don't think that there's going to be large new comprehensive proposals. I think the next big proposals that will come out will be in response to the various initiatives that have been a part of the reform effort.
Great, thanks for that. I want to turn a question that Jonathan rose in one of the sessions I was in with him today, and you touched on this a little bit, and in a number of our panels today, we heard a lot about education, because certainly that is grabbing the headlines, so to speak. Certainly the fines that the legislature is under and the discussion occurring next week. And then, of course, we had the Supreme Court ruling here recently on charter schools. Building on what you were saying earlier, will there be oxygen in the room for other issues? And Jonathan talked earlier about, will this impact funding for healthcare, all the necessary focus on education? Jonathan, do you want to start?
In part, I'll respond by paraphrasing what I think we heard from the legislators to whom this was asked, which is, yes, it very well may impact, and that is, as I suggested in that room, the elephant in the room, which is the legislature has yet to meet the Supreme Court's, as defined by the Supreme Court, its obligation to fund education in this state. That funding will need to come from somewhere. And that those of us who care about healthcare will need to continue to be vigilant that, if you will, our interests, the interests of the companies and the patients that we care for, are not sacrificed to meet, albeit another very important state need. But I think again it will dominate. It may be the dominant discussion in the legislature, with the very real possibility of impacting. In the end, everything there is connected. Of impacting that, and it's like I say, I think it's something that we that care about healthcare will want to keep an eye on, because because there could be consequences.
This is an interesting thought. There are two parts to it. One is, yes, it's going to be competitive. If they do fund anything, there's going to be a huge drive not to put new revenue in, at least not too much new revenue. And my concern is not just healthcare, but I think I just think of the political calculation. If I don't want to have any new revenue, don't want to say I voted for taxes, that leaves a constitutional crisis, or at least a big argument with the Supreme Court about who has the power to do something. And I could see that I see a three-ring circus that could be going on. And we may end up with no funding there. I could see that being one of the courses. I know the governor is very dedicated in making sure we do get good education funding, but I haven't seen the movement that you'd like to see around that, any consensus at all about revenue, and that's going to be there. If there's no revenue, then I think we all have to make sure we tie our shoes on tight, because we may lose them. Yeah.
And one of the things that I think gets lost in a lot of the conversation around the funding to make the McCleary mandate or fully fund McCleary is the $2.3 billion in new resources that the legislature has committed to that decision over the last two biennia. So there has been a significant amount of resources invested in the K-12 system. I am hearing more and more angst from lawmakers who are wondering about what it means for human services, what it means for higher education, what it means for healthcare. And I think Senator Frocht earlier today said, I don't know that we can anticipate in the state the same robust level of economic growth that we are seeing right now. So I don't know that we're going to see that this year. I mean, there's one question about how the legislature deals with the contempt order. Different opinions about how that can be addressed right now. But long term, I think there's a larger issue about where K-12 stacks up with all of the various things that need to be funded by state government.
Great. My next question, I have individual questions for each of you. So my first question is for Dr. Crittenden. Now that you've been in your position for a while, can you compare working on healthcare issues for Governor Inslee versus your time working on healthcare under Governor Gardner?
Night and day. And the nice thing about this time is that we're actually implementing something. Last time we debated a lot, and we did pass a bill in '93. That's a long time ago, and it was actually not too dissimilar to what we're doing now. There are puts and takes. But we did not have the broad consensus. You know, it was done by, say, on one side. It was not. There was no by that one party really supported, the other party didn't. So when it reversed party control, it disappeared. But also, we didn't have any federal support. And one of the things that makes it more, that gives us the ability to build on what we have now is we have the ACA under us. We have the funding for the Medicaid expansion. We have actually funding for like our SIM grant and a lot of the things we're doing. And so it actually is a lot of fun this time to be able to implement. And we have a great team in the state through HCA, DSHS, DOH, and OFM who are working on this. And so I think, you know, it's kind of fun to watch it go. You know, a lot of us all around here, we all worked on parts of this over the years, and now we have it and we have something to play with. So it's good.
Can you get a little follow-up? Tell me a little bit about your new role, because I've heard different things. You're going somewhere, you're not going somewhere, and I've said, no, he's still around.
I am going somewhere. I'm going across the street, actually. So I'm in policy. I was in policy, and I'm theoretically now in the governor's office. And the only reason we did that was that we had identified with the executive team that the biggest risk we run is not being successfully implementing our mental health reforms. In other words, we're trying to integrate mental health. We have that by 2020. We have the BHO in 2016, full integration by 2020. We have two agencies who have in two different funding streams, entirely from the federal level on down through with different providers, lack of communications at all levels, and we were at risk. I think we're still at risk of not coming around to some, I'll say, unanimity about where we're going. And I think the providers, it's not fair to them, it's not fair to anybody if we don't have some agreement, at least at the state level. So we're looking very much at how we both figure out what are the choices available. How do we make those decisions? I'm not going to do the administration, but I get to advise the governor on what, I'll say if we have to do tiebreaker, circuit breaker, we get to make that decision. So I find it to be a good thing. I see this as one of the, in all of my practice, I was a family doctor for a long time. My first hire was mental health into my clinic in Southeast Seattle, in the poor area of town. And ever since then, I've integrated mental health into my care. And it's no doubt that if you do that, you get much better outcomes all the way along. And we have this huge division between the severely mentally ill and everybody else. And we've done very poorly with the moderate and mildly mentally ill. And so we need to improve that. We need to connect them. We need to do a lot of things. And so it's actually kind of fun to think about.
So you're here to stay, to spell those rumors right now.
Yes.
You're still playing. Great. So Jonathan, you've had a lot of hats, but right now you're working with Molina as well as with the Healthcare Authority on accountable communities of health. So all the state healthcare innovation work is on top for you. Curious what you're hearing and what's your take on whether the ACHs will be able to deliver on these implementation plans?
So I guess I would say that the short answer is yes. That I think, or maybe, and then quickly it gets to the longer answer, which is it's not that simple, but that conceptually it is an extremely sound approach that we need be very thoughtful and precise in its implementation. I think there's an appropriate anxiousness. I guess I would say this, which is, since the moment that the Affordable Care Act passed, it has been, the implementation has been an exercise in uncertainty, with the court cases, which isn't necessarily a bad thing. It's just, it's a world in which we have all had to learn to live in. Innovation, by its very nature, is unsettling and uncertain. If it wasn't unsettling and uncertain, it probably wouldn't be innovation. So I think the key, I think, is that we need to take the conceptual ideas that are behind the ACHs that say collaboration at the local level, bringing in both clinical care and social terms of health, has the promise to deliver better care, lower cost. And we need to take it at the conceptual level and correctly translate it to the concrete level. And I think that's the real challenge. I think it's a real challenge in a number of ways. It's a challenge to those wondering whether they can support this. It's a challenge to those who may be affected by it. So I don't think there's any question conceptually it is sound. It's based on a history in this state of strong community engagement with regard to healthcare, and the key to its success, be it from the perspective of a managed care organization like Molina, providers like family physicians, is the ability of the state and the other actors, again, to translate the conceptual idea into sound, concrete implementation. I told somebody earlier today, I had a graduate school professor who said, policy is what you do. And I think that will be really key with this, is that what actually happens in these communities will be more important than how these ACHs are defined out of Olympia. But I, in hearing from the pilot ACHs, there's reason to be encouraged, but they also need to be held accountable, and I think that will be important too.
Thank you. All right, my final for Jeff. So you shared with me that you were young when you were first elected to the legislature.
There ought to be a law. I was way too young.
Way too young, yeah. And like president. We're all obviously a little older now, and you're wearing a different hat. So I'm curious your thoughts about tackling these complex issues from the role of a legislator and now as a contract lobbyist with multiple clients with multiple issues and priorities.
I'm really struck, and I think that the legislators that you had here today, I'm just struck that we continue to get really good people to run for public office and that want to take on responsibilities in public policy. I think that particularly the folks that have worked in healthcare policy in the last few years have done so in a very thoughtful, very bipartisan manner. They disagree, and oftentimes that disagreement is really worthwhile. I think Representative Schmick said earlier today, oftentimes there's divided government and there's a role for both parties to play, and I think you get better debate, and I think you get healthier debate. And it's the same thing within the clash of various interests that Jonathan and I would represent in the legislature. I think that we get better public policy when we have voices and when we have robust argument and when we hash that out. And oftentimes we don't have certainty as to what the outcome's going to be. But I think that when there is clarity about arguments and position, oftentimes we're going to end up with a better product.
So I'm going to turn back a question to all of you. So a prime topic of conversation today has been the 1115 Medicaid waiver. Heard about that at lunch and a number of workshops about that. So I'm curious how you all think this will play out legislatively. And I'm also curious, we've heard some concerns about, for example, the focus on social determinants of health and potential sustainability questions financially, as well as are accountable communities of health ready for this new role? So I'm curious how you think it will play out legislatively. I'll start with Dr. Bob.
I think this is a great opportunity. I think people have thought very hard on this 1115. I think, I can't remember which, it was Nathan or Mary Ann who mentioned it, but there's been a lot of work over the past year trying to figure these things out. The value of the 1115 is it allows us, with almost no investment from our state, in fact, very little, to cash in, if you want to call that, on the savings and good work that's been done in the past, to invest that savings into really converting our system. And I think that it's a little like taking the SIM grant, putting on steroids. We can really get some things going. Now, the caveat there, though, is that we have, it's a sustainability issue. Those investments can't just be willy-nilly. They have to be on things that actually impact the budget, because if the investment decreases the budget overall, then those investments will be continued by the legislature. They'll see that as, it'll cost them money basically to take away the investment. If the investments don't have good ROI, they will be subject to cuts as we go forward and won't be sustainable. So it's going to be up to the agencies and the ACHs to choose those investments that not only make a difference for their community, but can be sustainable over time. But I think it's an opportunity. The risk to the state, and this has been a big issue for the governor's office and the OFM, has been that we want to make sure that we put the state at no risk for losing in the long term. And we have worked out some parameters around that, which we think are safe. So we're looking at that. As long as we can negotiate those with CMS, we'll be fine. And I think going forward, it'll help a lot of communities. I mean, this will be enough money that we can actually do things that we've talked about for years in communities and move things in a direction that make a lot of sense.
Okay. I think that it's a terrific plan, and we'll kind of see how it goes. Washington State has a great track record in this area. I want to say a few years ago, the journal Health Affairs noted that they were making recommendations on state Medicaid programs and highlighted Washington State, particularly as it related to cost containment. I think everything that was laid out in the lunch presentation as it relates to value-based purchasing, as it relates to the other initiatives are all issues where we need to be focused on. And I think generally speaking, the system's headed in the right direction. I think that we've bitten off a lot. I mean, when you look at 560,000 people now having insurance that did not have it pre the adoption of the Affordable Care Act, I think we're moving in a very bold policy direction. And with that, there's the warning of whether or not our system is taking on too much. I think there will probably be some legislative conversation around that. But given the track record and given the issues that are at stake, I think it's a step in the right direction.
I would agree there are reasons to be enthusiastic. There are reasons to see this as an enormous opportunity. And I think maybe the only thing I would add is that there's a very appropriate role to be played by the legislature in something like this. And it gets back to what I said earlier, this notion of conceptual, translated to concrete. When I think there is a enormous obligation on the administration, on the healthcare authority, to be clear, be honest, be consistent in their explanation of what this is and what it could mean for the state. And I think it will be critical because, my experience on legislative staff and then on governor's staff, the critical role that legislators play in being the voice of people in their district. And the question is not simply, is it good policy, but how will it impact on a day-to-day basis the people that I will hear from in my district? And I think that's a question that in the discussions with CMS, in internal discussions about its eventual implementation, that HCA will need to keep in mind, and I'm sure that they will hear from legislators about. But again, the very appropriate role that I think legislators will play in terms of being thoughtful and wanting to make sure that in its implementation, it's of benefit to the people that they represent.
And I'll just say one more thing is that I think right now it sounds a little bit on the general side. We have ideas. One of the processes after this 30-day, what they call it, comment period on the federal level is going to be a series of very in-depth discussions about the amount, what the investments, the amount, how we're going to manage those, what are the actual investments that the CMS is going to support. And I think it's only fair to the legislature that before they make any decision, they know detail about what we're going to do with this, what their risks are, what happens in their own communities, all those things. And I know that HCA and DSHS and are involved in this very much, and they're going to be doing a lot of discussions. And I trust that we'll have good detail for the legislature at that time.
Great. At lunch, we heard Mary Ann Lindeblad shared that our state's uninsured rate has dropped from, I think she said nearly 17% to 6.8%. And I know here in this region, we're lower than 5% thanks to the work of Better Health Together and its immense team of in-person assisters. As we've heard throughout the day, though, we know that coverage doesn't equal access. So I'm curious, and start with you, Jonathan, where you think those discussions will go about working to improve access. I will also note that in terms of last year's state of reform to this year's state of reform, we've made a number of progress around residencies, and of course, in this right down the street, we'll have a new medical school here in not too long, and clearly that will help address some of the problem. But
I think that the question of access may be the next big question in this sort of evolving implementation of healthcare reform. And I say it in this regard, we really have the opportunity to redefine what we mean by access and identify the tools. We've already started down that path. We talk about telemedicine. And there was a time when access meant to many that I get in to see a physician face-to-face, no more than a day or two after I make the phone call to that physician's office. We have the opportunity to substantially redefine access to care in a way that provides better care at lower cost. And I think we're only on the, you saw some of that in the discussion about network adequacy. I think we're just on the cusp of that discussion. And again, I think that it may be among the next big discussions that you will see in a legislative arena, started by the discussion about telemedicine and the role that it can play. There's the role about at the highest level of your license. And the discussion within the ACHs about integrated care and the ability to connect people to the services they need. So I guess I would say this, it's an important discussion, and I think that we would have missed an opportunity if we don't realize that what we've been presented in terms of redefining access and then devising solutions in addition to enhancing if you may, the traditional healthcare workforce, thinking about different ways to access them and to supplement what we have in place. So I would suggest, in the next 5 to 10 years, we will have a legislature and administrations full on engaged in that question of what is access and redefining what we all think of it is to actually see a healthcare provider in Washington State, which is exciting.
I had a friend who owned a printing business that had a sign on the wall that said, great printing, good, fast, cheap, pick any two. And I think that's the challenge that we've got right now also. When it comes down to quality, cost, and access, it's while we're driving towards this and trying to get more people into the system, as Jonathan has been saying, out there where the rubber meets the road, what does it actually mean for an individual patient as it relates to seeing a doc? And I think Mary Selecki had said earlier, talking about vaccination rates, if you're only paying $5 for a primary care doc to administer a vaccination, you're going to end up with access challenges. I know my primary care doc in Olympia had a sign up for a period of time that said, I don't take the following insurance, and it was all of the Medicaid managed care organizations. And I asked him about that at one point in time, and he just very frankly said, at my age, I got to worry about retirement. I saw these folks when I was younger, and I've got to worry about that now. So not looking at the differential, taking the differential on the Medicare reimbursement rate doesn't help along those lines. But I think issues with access and cost and quality are going to be continually what we're looking at, and they're going to be a continual challenge.
This is a very good issue and one that's tough, but I also think we're in an interesting time. We've always, whenever we talk about access, it's always been workforce, payment levels, distribution, things like that, and those are all important. But the interesting thing right now is I don't think the state can solve some of those, but it really is amazing when I reach out and talk to different, both in the provider community, the insurer community, you see the activity that's going on of people, of different groups. The accountable care organization, ACPs that we have now for the state employees through the university, through VM. You have the practices throughout the state, and I don't know if Carl's still here, but the family doctors are doing a lot of work on this. The pediatricians are looking at how they redefine. And everybody's looking at how they redefine how they practice, and I think it started even before a few years ago is when we first did first it was Diabetes Collaborative, then it became the Primary Care Medical Home Collaborative, but things like that have been kind of cooking for a while. And what I'm seeing now is that it's like on steroids. I mean, they're everywhere. Everybody's working on things, they're recreating, they're trying to figure out how you use people most effectively in organizations. It's just really phenomenal, I think, on the medical side. Then I look at the mental health side, and everybody's looking at how do we restructure this. So we're looking all over the country. Well, what's the best way to restructure mental health so it works well with physical health? I mean, there's just a lot of very big interest in trying to figure out how do we define the practice of care, which is going to drive the access, because if you use people more efficiently, you probably don't need as many, but you also can pay them differently. And then you're going to have, always going to fall back to the state to a certain extent about how we fund Medicaid, how we fund our state employees, how we do support for say workforce issues and other things. But I'm just quite impressed at how much the world's being defined differently than it was before, and that from that model that'll be out there, models that'll be out there, then you have to kind of drive the other part of it the state can do, kind of more reflective of the real world out there as opposed to us creating it.
We only have a couple more minutes. I have a couple quick questions. I'm going to start with Jeff. So you all are deemed Olympia insiders, and here you are sitting in Eastern Washington, in Spokane. As Olympia insiders, what advice do you have to impart on us Eastern Washingtonians?
That's a dangerous question.
Boy, I think that Eastern Washington does a very good job of advocating for themselves. My experience, Andy Billig's still not here, but he would talk about how oftentimes when Greater Spokane Incorporated would organize folks to come over during the session, that there was recognition for how well organized that they were. I think Eastern Washington's done very well basically since I left the legislature. So you look at this campus over here off to the east. I mean, it's grown leaps and bounds. So probably the best thing was getting rid of me. You got in some good folks, and now there's some large buildings. So,
Is this where I agree with everything that Jeff just said? I guess I would say a couple of things. That those that you send in East Washington represent you in the legislature do a very good job of that, and you need to take advantage of that. I have always been impressed. And you always get the sense when you fly over here how really grand it is, the attachment of your legislators to where they're from and where they live. There's no question in my mind the degree to which they bring what you care about to, in their suitcase with them when they trek across the mountains to go to Olympia. The second thing I think I would say is the notion of just like a DC Beltway and Olympia Beltway is in fact a real thing. There is inside the Beltway think. It is not limited to just the exclusion of an Eastern Washington, but it can tend to exclude those who are not inside that Beltway. So I would say always be mindful and willing and speak up again about the impact of what happens in Olympia in the day-to-day real-world lives that you have over here in Eastern Washington, because it does matter. And again, that is not due to any ill intent on the part of the folks in Olympia. It is a simple byproduct in part of distance, in part of the job that they are tasked with doing. But I would encourage you to continue, be vigilant in being the voice for the impact of what happens in Olympia on your day-to-day lives, because sometimes that day-to-day stuff can get lost in the high-level policy discussions that take place in the Olympia Beltway.
And I just believe in what's the right word of saying this. I think people in Olympia, myself included, we all like to think we think everything through, but we really, I like to get in front of parades that are already going. In other words, I always have believed that grassroots is where, back home, or if you want to do it, organized grassroots, coming to Olympia with multiple different towns, legislators, all warmed up on the same issue because it's good for their local community, makes policy much more easy to make in Olympia. In other words, you have a parade, you get things organized, and then people will get in front of it and support it. You have to fight over the partisan issues, the money issues and stuff like that, but it makes it a lot easier to get something through. And I guess the question really is what I think is helpful for you folks. One is you do have a pretty good organization over here that's been very successful, and I think you look at the amount of asphalt per person, you've been very successful too. But I think build on that, and I think how do you want to create the health system? What do you want to have happen? Find other communities and everything. You have a real power there that you can really organize and help move the discussion on all these issues. I mean, you have to think about a year and a half ahead of where you are right now. What's going to be the issue that's going to be debated? Then you figure out, what do we want to have as part of that debate and organize those things and bring it to your legislators, you get other people to bring it to their legislators, and pretty soon you have a good-sized parade, and everybody in Olympia would likes to get in front of a successful parade.
Right, DJ's about to walk up here. I'm going to ask one final question. Do any of you want to weigh in? It's January 2017. Who's living in the governor's mansion? Who's got the majority in the House and the Senate? Any of you want to give your prediction? What's going to change? Okay.
Inslee's in the governor's office. It's going to be a 5-vote majority for the D's on the House side and a 3-vote majority for the R's on the Senate side.
We should put that in an envelope and see what we think. Any of you gentlemen want to weigh in on that? Put you on. Smart, very smart, very smart. All right, well, I thank these folks very much for their candor and good insights, and I'll turn it back over to our host here. So join me in thanking them.